Great, thank you so much. I really appreciate the opportunity to speak to you, particularly this elite group gathered here in this room today. See if I can advance my slides here. Dr. Rogers, this is my disclosure for complete transparency. I don't think that I'll be discussing this today, any of these conflicts of interest that I have. So I'm going to speak about Oxalobacter formigenes. My colleague, Dr. Lama Nazal, will discuss her more recent data later today, and I don't think that we will overlap completely. Oxalobacter, of course, has an importance that I'll discuss, but when I go back to the title, Can the Microbiome Help?, I'm going to suggest that it's important, but I don't want to keep you in suspense. I'm going to suggest that we don't know the answer. This is a gram-negative obligate anaerobe. It has one substrate. It only eats oxalate. That's how it makes ATP, so that its presence has been associated with diminished urinary oxalate, and it's been thought to be protective. And the data go back to, I think, in the history of looking at the clinical importance of Oxalobacter. Harmeet Sidhu published this data in the Lancet some time ago, looking at patients with cystic fibrosis. And my family has a particular interest in cystic fibrosis. It's what my wife does research in. And so we have paid attention to the fact that if you look at this line across this graph, the line of, let's say, normal urinary oxalate on the y-axis, and look at patients of various ages, patients who had Oxalobacter present in the black circles were below the line. They had lower urinary oxalate. No patient with the presence of Oxalobacter in the stool was above the line, having abnormal amounts of oxalate in the urine. So Harmeet also published these data suggesting that looking at, on the y-axis here, at Oxalobacter colonization, the more kidney stone episodes that a patient had, the fewer of those patients were colonized with Oxalobacter. But the problem with these data was that they were not prospective. This was simply a retrospective study, so it made sense that if patients had more kidney stone episodes, they would also have more antibiotics, perhaps, and would have eliminated their Oxalobacter colonization. So it didn't clearly indicate that the microbiome was causative for kidney stone episodes. And back in 2004, it's amazing how far back this goes, I wrote this critique of the role of Oxalobacter in stone prevention, pointing out that patients with cystic fibrosis had other reasons to have kidney stones, and that perhaps Oxalobacter wasn't so important. And because I'll refer to this later, we also wrote this review of the association of kidney stones with cystic fibrosis, pointing out that these are patients who have abnormal loss of salt and water, and a variety of other dietary abnormalities have been ascribed to cystic fibrosis and the like. And we concluded that patients with CF could be increased compared with controls in terms of their kidney stone numbers, but there were many other possible episodes, mechanisms that were implicated. So we wanted to demonstrate whether or not antibiotics were perhaps important in a prospective manner. And so we wanted to see whether we could show that antibiotic use would lead to the elimination of Oxalobacter. The studies that showed, there were several studies showing that patients with more antibiotic use had less Oxalobacter, but those studies were not prospective. So we had to show prospectively that patients could give us a stool sample and demonstrate that they had Oxalobacter or not before receiving antibiotics, and then look to see what happened after antibiotics were given. And that's hard to do because obviously a patient comes into the emergency room with pneumonia, they're going to get antibiotics quickly. You won't have the opportunity to have them sign a consent form and get a stool sample to see what happened. But we really thought hard about this. And I'll just point out that Milt Allison, who discovered Oxalobacter, and I personally think, if the guys that discovered Helicobacter pylori won a Nobel Prize, I don't know why kidney stones aren't as important as gastritis and peptic ulcer disease. I think Milt should have really reached greater levels of notoriety. He just died in March, and I think it's important that we recognize his important contribution. So in order to demonstrate that we could give a course of antibiotics and demonstrate what happened to Oxalobacter, we realized that H. pylori was a group of patients who don't get treated immediately. The gastroenterologist calls and says, you have H. pylori in your stomach, come in next week, next month, and get a course of antibiotics. It was a perfect opportunity to have a patient who sign a consent form and give us a stool sample. They could, then we could compare groups of patients that had H. pylori who were treated with antibiotics compared to the control group, had an endoscopy, did not have H. pylori, and therefore were not given a course of antibiotics. And in the study, which we published in 2012, all of the patients that were in the study had Oxalobacter colonization. If they didn't have Oxalobacter, they were not eligible to be in the study. So we took only the group of patients that were positive. And in New York City, the prevalence rate of Oxalobacter in this population was 32%. That kind of low rate that's seen in developed countries. So 100% of patients had Oxalobacter, everyone else was excluded, and the patients were then treated based on their gastroenterology prescription with a course of antibiotics. Most of them received amoxicillin and clarithromycin. Some patients received metronidazole. And at 1 month, we looked for Oxalobacter presence in the stool. The patients who got antibiotics in blue were down to 31%. The patients who did not get antibiotics were at 86%. At 6 months, this was a persistent change. That remained true that if you got antibiotics, you were much less likely to have Oxalobacter in the stool, while the patients who didn't get antibiotics, the control group, was important. So that is 2012. The question then would be, okay, would we follow those patients? No, this is not a group of stone patients. They're simply being treated for Oxalobacter. But the idea that this could be important was summarized in this slide. This is from Felix Nauf's article suggesting that immunity, the microbiota, and kidney disease could be related, and of course that courses of antibiotics here on the left side would perhaps lead to changes in the microbiome that could lead to changes in degradation of oxalate and lead to changes in absorption of oxalate and reduce kidney failure. And of course, Felix has been important in suggesting, as Saeed Khan has been as well, that as well there is evidence of inflammation, that oxalate is a toxic substance that promotes inflammation, as Dr. Khan told us slightly earlier. So this paper, and then published in 2018 with my colleagues Greg Tazian, Michelle Denberg, and Jason, really is the culmination of the idea that those courses of antibiotics were important. Here, the THIN database, this is the Health Improvement Network database from the UK, demonstrated for the first time that courses of antibiotics were associated with increased rates of kidney stones. So this is the odds ratio on the x-axis for sulfa drugs, cephalosporins, quinolones, and nitrofurantoin. In blue, within the first year, the odds ratio of having a kidney stone was 2 to 3 times greater. That effect, going from blue to red, wore off to a degree. In other words, that presumably the antibiotic effect diminished over time, and so that the course of the likelihood of a kidney stone was greater in the first year and decreased in the years from 1 to 3. This was the first prospective study demonstrating that effect, and the odds ratio for these different groups was anywhere from 2 to 3 times higher. And I will point out, you see H. pylori treatment. That was something we had suggested based on our first prospective study of Oxalobacter colonization after treatment with for H. pylori. These data particularly show that these were younger age groups that were much more likely to have this. And there are some suggestions that young people have better reconstitution of their microbiome following courses of antibiotics. That's been looked at in a variety of other diseases other than just kidney stones. But you can see that the effect was greater. The odds ratio for a kidney stone was greater after a course of antibiotics in younger people. All of these lines are greater odds ratios for younger people. So is this effect due to the elimination of Oxalobacter? It could be and maybe not. Some of the antibiotics that we looked at are drugs that Oxalobacter is relatively resistant to, so we certainly did not try to claim that this was only due to Oxalobacter colonization. It's certainly true, though, that other organisms in the intestine might be important. And there's the possibility that is really only now being looked at for the first time, that there is such a thing as the urinary microbiome. And I can't comment much on that, but the idea that urine is sterile perhaps is not true. Perhaps there is a urinary microbiome that's relevant. And there's lots of data like this. And I'll show you, this is again my friends at Children's Hospital in Philadelphia, Michelle Denberg and Greg Tajian, looking at in blue, the kidney stone patients, in yellow or orange, the control group. All of these taxa were in less prevalent in the colon and the microbiome of stone formers in comparison to non-stone formers. So there's a difference in the microbiomes. The significance of this is not completely clear. And one of the interesting things about Oxalobacter, it degrades oxalate, and so we know exactly what its metabolic effect is. All of these other organisms have a variety of other metabolic pathways, and how they affect urinary chemistry remains unclear. So patients with kidney stones have a lower overall diversity of the gut microbiome. It's likely that multiple organisms could mediate the association between kidney stones and antibiotics, and it's likely that these organisms work together to have these effects. I'll just show you a couple of other things. Manuel Ferrero and Gary Curhan have shown a similar idea in women, in the female in nurses and nurses' health study. If you got antibiotics over the course of many years that lasted less than 2 months in duration, you did not have an increased rate of kidney stones. But women who had a course of antibiotics that lasted more than 2 months were 36% or 48% more likely to have a kidney stone follow-up. Then we've just recently published this data on my long-term interest in cystic fibrosis with Eric Taylor, urinary stone disease in patients with kidney stones. We studied 29,000 patients in the cystic fibrosis registry and demonstrated that one of the risk factors for kidney stones in this population was chronic macrolide therapy. Diabetics,
David,
of course.
could you wrap up?
Yes, and diabetics and hypertension patients were more likely, but most importantly, chronic macrolide therapy was associated with a higher risk of kidney stones. I'll just point out that there's increasing evidence that antibiotics increase the risk for metabolic diseases, neoplastic diseases, as one of my mentors, Marty Blazer, pointed out. And so the question, can antibiotic usage account for increasing worldwide prevalence of kidney stones? I think it's likely. Antibiotics are over-the-counter and have very little oversight. So can the microbiome help? There's a role of the intestinal microbiome in influencing urine chemistry. Antibiotics are associated with stones. The microbiome is likely responsible for these observations, but there are no data demonstrating that changes in the microbiome, changing the incidence or prevalence of stones, can be accomplished. We need to do, perhaps, fecal transplants or something a little bit more than simply giving a single organism. Thank you for your time.